Good morning. I just
Good morning, colleagues. The subcommittee will come to order. We're meeting today to consider 9 bills. Due to the COVID-19 public health emergency, members can participate today in either in person or remotely via online video conferencing. Members, staff, and members of the press that are present, well, I don't see any that are present, must wear a mask in accordance with the updated guidance issued by the attending physician. For members participating remotely, your microphones will be set on mute for the purpose of eliminating inadvertent background noise, and members participating remotely will need to unmute your microphones. I think everyone has caught on to the drill, but it's important to restate it each time you wish to speak. Please note that once you unmute your microphone, anything that is said in Webex will be heard over the loudspeakers in the committee room and subject to be heard by the live stream and C-SPAN. I ask that members participating remotely use the raise hand feature of the software platform when you wish to be recognized, including to give an opening statement or to offer an amendment. After you're recognized to speak, please use the lower hand feature of the software platform so I know that you no longer seek recognition. During voice votes, members participating remotely will need to unmute yourselves so that we can hear your response, and during recorded votes, you will need to unmute yourself once your name is called to respond to the clerk. In responding to the clerk, I ask that instead of just saying aye or nay, that you respond with a phrase like Anna Eshu from California votes aye. This will provide an additional time for the voting member to be identified and made visible on the platform. Since members are participating from different locations at today's markup, all recognition of members, including for opening statements and amendments, will be in the order of subcommittee seniority. During this markup, amendments will be sent to members electronically, as we did during virtual markups. Members participating in person should not bring paper copies of their amendments to the clerk's desk. If a member participating in person would like a paper copy of an amendment or bill, please alert the staff during the consideration of the amendment or the bill. Amendments and motions should be sent to Perry Hamilton and Megan Mullen, and documents for the record to Megan Mullen at the email address we've provided to your staff. The chair will now recognize herself for 5 minutes for an opening statement. Today, our subcommittee marks up 9 bipartisan bills. 3 of the bills are children's health bills that seek to prevent and reduce the impact of stillborn, newborn, hearing loss, and birth defects or anomalies. I thank our fellow Health Subcommittee members, Representatives Carter, Trahan, Hudson, Guthrie, Matsui, Mullen, and Castor for their leadership in sponsoring these bills. We're also marking up the Dr. Lorna Breen Healthcare Provider Protection Act, which was introduced by Representative Wild and 14 bipartisan original co-sponsors. Our subcommittee was honored to host Mr. Corey Feist, who testified at our hearing last week, I think it was last week, and Ms. Jennifer Breen Feist, the brother-in-law and sister of Dr. Lorna Breen, who died by suicide after experiencing the first wave of COVID-19 patients. They asked us to move this bill forward quickly since the Senate has already passed it, and I'm proud that we're delivering on that promise today. We're also considering 2 bills to improve cardiac care and oral health literacy. The Carroll Act is named in honor of Carol Level Barr, the wife of Representative Andy Barr, who died last year of sudden cardiac arrest. The bill funds NIH and CDC to support research and public education for valvular heart disease. 2 bills provide loan repayment for the healthcare workforce to provide long-term support for future workers, including public health workers. This bill is sponsored by Representatives Crow, Dr. Burgess, and Ranking Member Guthrie, and myself. Lastly, we're considering major legislation by Representatives Quigley and Fortenberry to advance treatments for ALS. Every member has heard from constituents with ALS who are fed up with the lack of options. The Act for ALS will help patients take part in the expanded access program for experimental ALS drugs while providing a framework for the NIH and the FDA to benefit from the data of patients. We're moving the Act thanks to the tenacity of the ALS advocates, including Brian Wallach and Sandra Abrevea. They made a compelling case during our hearing for why Congress must do more to address this disease, which is a death sentence. These 9 bills represent significant progress. I urge Chairman Pallone to build on this progress during the full committee markup by including 2 bills that our subcommittee already heard. We were prepared to mark up those bills today, but they were removed from the public bill list on Tuesday of this week. First is Representative Raskin's Children and Media Research Advancement Act. As Dr. Radesky testified during our hearing, this bill is, quote, highly practical and good public health. We're at a crucial moment for understanding how media affects children, and CAMERA deserves urgent consideration. Concerns that this bill helps big tech in any way are specious and should not be taken seriously, and I urge the full committee to take up the bill. Secondly, I'm incredibly disappointed that Catherine's Law was not included in this markup. During our hearing, we listened to our former colleague, Congressman Rick Nolan's plea to save the lives of non-smokers who develop lung cancer by getting the early detection needed. Not one member uttered a single word of concern about the bill during our hearing. Nearly 25% of all cancer deaths in the United States are due to lung cancer. If lung cancer in never smokers were a separate category, it'd be in the top 10 cancers in the United States for sickness and death. The evidence that current lung cancer screening guidelines, lung cancer screening guidelines are insufficient. They do not follow the guidelines set by the National Comprehensive Cancer Network, and I'd like to enter into the record JAMA's new USPSTF guidelines for lung cancer screening, entitled Better But Not Enough. And I ask that, no objection, thank you. So I urge Chairman Pallone to take up the bill during the full committee markup to provide the coverage of lung cancer screening for individuals over the age of 40 even if they have no history of smoking. That's what Catherine died from. I now recognize, and pleased to, the ranking member of our Health Subcommittee, Mr. Guthrie, for his opening statement.
Thank you, Madam Chair. I appreciate the recognition. And before us today, we have several public health bills pertaining to critical prevention and early detection efforts for children and families, including my bill on early hearing detection and my Kentucky colleague Andy Barr's CAROL Act. And I'm pleased that today's markup continues our committee's bipartisan tradition. However, we have a bipartisan position, but on this side of the aisle, I want to stress that we're growing increasingly frustrated with the Democrats' reconciliation package. Democrats are trying to fit their entire legislative agenda in one bill. Yesterday, Democrats dropped over 2,000 pages that will get the government more involved in our lives from cradle to grave. And I'm afraid we're hastily going down a path where no one will actually have the time to understand what's in this legislation. I guess we'll have to pass it to know what's in it. And I say that because we still do not know the full cost of this bill or how all of the parts fit together, are supposed to fit together, yet it could be up for a vote we're hearing as early as this week. Also has been resurrected a version of the partisan H.R. 3 drug pricing plan that this committee voted not to advance this policy when it was before us in September. And I was encouraged that some of our Democrat colleagues recognized the devastating impact this legislation would have on the next generation of cures and medicines and how it would politicize the price of and access to life-saving drugs. The Nonpartisan Congressional Budget Office and numerous other independent analyses have concluded that H.R. 3 would stifle innovation and result in significantly fewer cures and treatments. And yet, we're not going to give this version of H.R. 3 a chance to be scored like the CBO or to be analyzed by the CMS Office of Actuary at this time, like they insisted on doing during the original Medicare Part D debate. Consequently, we won't know how many new cures we would lose, how new drug launch prices would go up, or how seniors' premiums might rise. I strongly believe that we must invest in biomedical research to discover innovative solutions to prevent, detect, and treat disease. And it's a shame we won't allow for more time to better understand how these policies would hinder the development of cures, impact a vast interconnected biomedical system, and affect patients who benefit from innovative treatments. But while I'm disappointed that the actions taken by my colleagues on the other side of the aisle this week, I'm glad we're here today to discuss several good faith bipartisan bills. One of these bills is the Early Hearing Detection Intervention Reauthorization Act, or EDI, which I have been proud to lead since 2015 with my good friend and colleague Doris Matsui. This bipartisan bill would authorize the EDI program, which provides early detection, diagnosis, and intervention for newborns, infants, and young children identified as deaf or hard of hearing. Additionally, I'm grateful that H.R. 1193, the Cardiovascular Advances in Research and Opportunities Legacy Act, or the CAROL Act, is included in today's markup. Representative Andy Barr tragically lost his wife, Carol, to sudden cardiac arrest in June of 2020. She was only 39 years old. At a young age, Carol had been diagnosed with an underlying condition called mitral valve prolapse, or MVP. To honor her legacy, he introduced the CAROL Act, which I'm proud to be a co-sponsor of this legacy bill that would address the research and awareness gap for MVP. This bill would instruct the CDC to carry out projects in order to increase education awareness or diagnosis of valvular heart disease. The CAROL Act would help many families avoid the tragedy that has so profoundly impacted Andy and his two lovely young daughters, and it will help others throughout the country. In closing, I want to stress that our concerns with the way we're moving forward on the reconciliation package, and want to note that we cannot continue to throw money blindly out the door without an oversight plan. We must be better stewards of taxpayer dollars. Without oversight or carefully examining where Congress is authorizing these funds, I'm predicting we'll be sitting here again with the American people frustrated when they find out waste and abuse examples of their taxpayer dollars being misused. I thank you for holding this hearing on the bipartisan bills, and I yield back.
The gentleman yields back. The chairman of the full committee is not with us, so I'll go to the ranking member of the full committee, Congresswoman McRogers.
Thank you, Madam Chair. Thank you for today's markup. Going through the subcommittee, through regular order, leads to better policy and better outcomes. Before I speak about today's bill, though, I would like to address the elephant in the room. new provisions in the reconciliation package, the tax and spending spree, that haven't had the chance for robust debate through our committee. The new version includes a series of punitive cuts and attacks on non-expansion states that would slash dish payments and uncompensated care claims for political gain in Texas, Florida, Tennessee, Alabama, Georgia, Kansas, Mississippi, North Carolina, South Dakota, Wisconsin, and Wyoming. Democrats claim that these states will be winners due to the tax credit expansion for low-income beneficiaries. What Democrats aren't saying is that the cuts will start before the tax credits begin and will continue even after the tax credits expire. Even with tax credits, hospitals will be less able to care for millions that remain uninsured without this critical funding. This is wrong. In order to strong-arm a Medicaid expansion on the whole country, Democrats are threatening the lives of patients who rely on care from hospitals in these 12 states. This is an abuse of power. Care for almost a quarter of our country's most vulnerable patients must be saved. It also included permanent increased funding for the Medicaid territories. This year, we held bipartisan hearings, markups for a compromise on how to extend long-term funding for the Medicaid programs in the 5 territories. We agreed unanimously to Mr. Bilirakis and Mr. Soto's bills for 5 years of funding that would be offset in a bipartisan way. In the tax and spending spree that was introduced last week, Democrats abandoned that deal. I hope that this is the last time that they walk away from our bipartisan agreements. It undermines trust, and it will jeopardize the future success of other bipartisan products in this committee. On drug pricing, new text released just yesterday, characterized as a compromise, raises the same concerns and some new ones compared to what the committee rejected in a bipartisan vote in this committee in September. While we are working to understand all the potential consequences, the proposal does not appear to have a reliable, across-the-board prohibition on the use of QALYs, quality-adjusted life years, similar tools for the government to determine the price on our lives that would be used in price setting. It continues to distort innovation, so drugs developed will be those Democrats and bureaucrats pick, not necessarily what the patient needs. This framework undermines incentives for the development of new drugs for older drugs, pediatric studies, and necessary antibiotics for superbugs. For parents fighting for breakthroughs, this, quote, compromise won't deliver hope, just more uncertainty for when or even if they can access life-saving treatments and cures for kids battling rare diseases. It's reckless in throwing millions, in some cases billions, towards programs that we haven't even had hearings on or authorized. For example, the bill provides $1.4 billion in mandatory funding for CDC's lab capacity, while the Select Agent Program is outdated and unauthorized. It's on top of the billions that have already been provided to CDC in the American Rescue Plan that have not been spent. The most recent text provides $300 million to the FDA, still without an official nomination for commissioner. FDA was not even germane at our markup in September. How did we get that number? Which centers will receive the funding? All these things should be addressed within this subcommittee. I'm pleased that we're going to work today on considering several bipartisan bills. The Carroll Act, certainly priority, introduced by our friend, Representative Andy Barr, in honor of his late wife, who tragically died from cardiac arrest. So important to supporting heart disease research. The Allied Health Workforce Diversity Act, critical to increasing access to allied health services in rural and underserved communities. The Public Health Workforce Loan Repayment Act. And I'll speak further when we consider this bill, but I just want to reiterate to my colleagues, plowing the hard ground to legislate is important. There's a reason that both sides of the aisle argue for regular order. And I'm so disappointed today that we're not using the expertise of this subcommittee to work on reconciliation. I look forward to the robust discussion, and I yield back. Thank you.
Gentlewoman yields back. Do other members seek recognition to make an opening statement? The gentleman from Florida, Mr. Bilirakis, is recognized for 3 minutes.
Thank you. Thank you, Madam Chair. I appreciate it very much, and I'll be very brief. Madam Chair, I appreciate you holding this markup to move forward bipartisan public health bills, including legislation I co-lead with my friend and colleague, Representative Cardenas, H.R. 4555, the Oral Literacy and Awareness Act. This bill is supported by multiple providers and patient groups who understand the importance of raising awareness in public education campaigns for oral health. We need additional evidence-based oral health literacy strategies to reach vulnerable populations, and this bill provides that first step. So I look forward to supporting it, and also the other bills, the bipartisan bills as well. And I yield back, Madam Chair. Thank
The
you.
gentleman yields back. Do other members seek recognition to make an opening statement? Not seeing or hearing any. That concludes our opening statements, and pursuant to committee rules, members' written opening statements shall be made part of the record, and members should submit written opening statements to the clerk's desk. All right, now we will begin our consideration of bills. The chair calls up H.R. 1193, the Cardiovascular Advances in Research and Opportunities Legacy Act, or the Carroll Act. The clerk will report the title of the bill, please.
H.R. 1193, to amend Title IV of the Public Health Service Act to direct the Director of the National Institute.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. Are there any members seeking recognition to speak on H.R. 1193? Anyone virtual? No? All right.
I have an amendment. I do have an amendment.
Are the gentleman has an
I do
amendment
have
at the
an amendment
desk?
at the
That's the purpose that the member seeks recognition.
Okay. I thought you said to speak on the bill, now the amendment process. Okay.
Right.
Madam Chair, I have an amendment at the desk.
I now recognize Mr. Guthrie, Mr. Guthrie to offer an amendment in the nature of substitute. The clerk will report the amendment, please.
Amendment in the nature of a substitute to H.R. 1193, offered by Mr. Guthrie of Kentucky.
Without objection, the reading of the amendment will be dispensed with, and Mr. Guthrie is recognized for 5 minutes.
Thank you, Madam Chair. I want to take a moment to commend Representative Andy Barr for introducing the Carroll Act. We all know Andy well. It's a legacy bill that honors his late wife, Carol, who tragically lost her life to sudden cardiac arrest last year. Carol was diagnosed with mitral valve prolapse, a common heart valve disease. Though most cases are thought to be benign, reported complications can result in sudden cardiac arrest. Unfortunately, over 25,000 people die each year in the U.S. from heart valve disease, primarily due to underdiagnosis and undertreatment of the condition. The Carroll Act helps address the underdiagnosis and undertreatment of valvular heart disease by investing in vital research that will advance technological imaging and precision medicine to enable intervention and treatment plans for patients. Identifying patients at high risk of negative outcomes from valvular heart disease can lead to saving lives. The amendment and underlying bill instructs the Centers for Disease Control and Prevention to increase public awareness regarding systems of valvular heart disease and effective strategies for preventing sudden cardiac arrest. The Carroll Act further ensures the CDC continues important initiatives with the Division of Heart Disease and Stroke, including those related to valvular heart disease. Specifically, the CDC will work to broaden the awareness of valvular heart disease and enhance surveillance of hospital cardiac arrest in order to improve patient outcomes. All of us, our still hearts are pouring out to our good friend and colleague Andy Barr, his two lovely young daughters, and we know that other families struggle from this as well. It's a good opportunity for us to make a difference in the lives and prevent other families from going through this tragedy. So I urge my colleagues to support this life-saving amendment in the underlying bill, and I yield back.
The gentleman yields back. Are there other members seeking recognition to speak on the amendment? The gentleman from Pennsylvania is recognized for 5 minutes.
Madam Chair, I wish to strike the last word.
So ordered.
Thank you, Chair Eschew, for yielding, and also thank you, Ranking Member Guthrie, for both of your work today in preparing the CARE Act for markup. I would like to thank my colleague, Representative Andy Barr, on his diligent work on bringing forward this important piece of legislation. Every year, over 25,000 Americans succumb to valvular heart disease, and many more, unfortunately, remain completely undiagnosed. This bill will invest in the critical research that will improve outcomes for those with this disease. This research will be primarily focusing on identifying risk factors in addition to advancing diagnostics and treatments, all aimed towards keeping patients healthy throughout their lives. Passage of the CARE Act will significantly expedite this research, and in the process, it will ultimately save lives. I urge the committee to adopt this amendment in the nature of a substitute, and I yield the balance of my time.
The gentleman yields back. Are there any other members who seek recognition to offer an amendment to the amendment? Seeing none, we will take this out. No further debate. We'll proceed to a vote on the amendment. All those in favor? Is it not on the amendment?
It's on the amendment in the nature of a substitute. We didn't have any amendments.
All those in favor of the amendment, excuse the chair, in the nature of a substitute to H.R. 1193, will signify by saying aye. Aye.
Aye.
All those opposed signify by saying no.
Okay.
In the opinion of the chair, the ayes have it. All right, we'll move on to. We're done. We'll now take a vote on final passage. All those in favor of forwarding H.R. 1193 as amended to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. What did you say? H.R. 1193 is amended, is forwarded to the full committee. The chair now calls up H.R. 1667, the Dr. Lorna Breen Healthcare Provider Protection Act, and the clerk will report the title of the bill, please.
H.R. 1667, to address behavioral health and well-being among healthcare professionals. A bill to address behavioral health and well-being among.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time.
Madam Chair.
Are there members seeking recognition to speak on H.R. 1667?
Madam Chair, I have an amendment in the nature of a substitute at the desk.
The gentleman is recognized for 5 minutes.
Thank you, Madam Chair. I'm proud to present this bill in honor of Dr. Lorna Breen, a talented physician.
Just a minute. I'm sorry. The clerk needs to report the amendment.
That's what I thought.
Amendment in the nature of a substitute to H.R. 1667, offered by Mr. Griffith of Virginia, Strike all after the enacting clause and insert the following. Section 1.
Without objection, the reading of the amendment will be dispensed with, and the gentleman is recognized for 5 minutes.
Thank you, Madam Chair. I'm still proud to present this bill in honor of Dr. Lorna Breen, a talented physician who lived her life in service to others. As our subcommittee heard from Corey Feist, co-founder of the Dr. Laura Breen Heroes Foundation and the brother-in-law of Dr. Breen, in his testimony on October 26, Dr. Breen was the director of the emergency department at Columbia Presbyterian's Allen Hospital. In the spring of 2020, in a span of 3 weeks, Dr. Breen treated confirmed COVID patients, contracted COVID herself, and then returned to an overwhelming number of incredibly sick patients. She and her colleagues worked around the clock with limited PPE, not enough oxygen, not enough beds, and not enough help. After 12-hour shifts, she and her coworkers would stay at work to help with the continuous flow of patients. By April 9, Dr. Breen hit her breaking point. She was nearly catatonic and needed serious help. But for fear that she would lose her medical license or be ostracized by her colleagues, that caused her to delay seeking necessary support and ultimately cost Dr. Breen her life. She died by suicide on April 26, 2020. Healthcare workers have faced a unique set of mental health and emotional challenges during this time. It takes a very special person to willingly take on responsibility for another human's physical well-being. I can only imagine the immense pressure these folks often bear and the emotional toll it can take on them. The COVID-19 pandemic brought to light the fact that our nation's system of healthcare does not adequately support providers' mental health. It has caused and continues to cause extreme levels of burnout. The legislation before us today aims to reduce and prevent suicide, burnout, and mental and behavioral health conditions among our healthcare professionals. Some funding for this purpose was included in the American Rescue Plan, and that included some funding for the purpose of addressing mental and behavioral health of medical professionals. We are here today to appropriately authorize discretionary funds for such programs. It is important to provide predictable funding for this program and a pathway for reauthorization in the future. Since we do not know exactly how much of the ARP funding has been released or which grantees it will go to, I would like to ask that the majority work with us on future oversight of this program so that we can determine how best to reauthorize it when the time comes. Companion legislation, Senate S-610, unanimously passed the Senate on August 6, 2021. I now urge my House colleagues to join me in supporting our healthcare workforce through the passage of this bill. And I would also have to say that I think that while we can't bring Dr. Laura Breen back, that this would be a worthy tribute to her efforts to help the American patient throughout her career. Thank you, Madam Chair, and I yield back.
Gentleman yields back. The chair recognizes herself for 5 minutes to strike the last word and speak on the bill and its aims. America's healthcare workers have been and continue to face a deadly crisis with heavy workloads, unpredictable schedules, and emotionally charged situations. Our healthcare workers have been experiencing unprecedented levels of stress and exhaustion. The pandemic has exacerbated this crisis. 3/4 of the healthcare workforce in our country now report being frustrated, overwhelmed, and burned out. 1 in 5 healthcare workers have left the workforce entirely. Despite these unsettling statistics, there has been really an ignoring of healthcare workers' mental health. Nearly half of our nation's healthcare professionals who need mental health treatment do not access it for fear of professional repercussions. And this was clearly the case when we heard the testimony of Dr. Breen's brother-in-law. As a result, physicians have the highest suicide rate of any profession, and it's estimated that 400 doctors die by suicide in our country each year. Dr. Lorna Breen, an emergency department director, died by suicide last year. As we heard from her brother-in-law at our hearing on the bill, when she hit her breaking point in the midst of the pandemic, she was too concerned about losing her medical license to seek out professional help. This legislation calls for stronger support for our caregivers to help them weather their physically and emotionally draining work. This comprehensive bipartisan legislation provides grant funding for suicide prevention and peer support at healthcare facilities. It also helps to make sure that healthcare professionals can ask for mental health help without facing negative consequences in their careers. This legislation has been endorsed by over 70 healthcare organizations spanning all aspects of the industry. The AINS aligns the authorization period from 5 years to 3 years to be consistent with the American Rescue Plan activities, makes programmatic changes to the scope and timeframe of the grants, adds a GAO study to examine duplication of programs across HHS, and makes technical changes with a greater focus on substance use disorders. The pervasiveness of the mental health crisis among the healthcare workforce has gone on for a long time. And as much as we depend on healthcare workers to care for us, especially during the pandemic, our healthcare workers are now depending on us. So today, we make their mental health and their livelihoods a top priority. And I join with my colleagues in urging that the full subcommittee support the bill and the AINS. Are there other members seeking recognition to speak on the amendment? Ms. Custer, all right. For what purpose does the gentlewoman from New Hampshire seek recognition?
Madam Chairwoman, I move to strike the last word.
Gentlewoman is recognized for 5 minutes.
Thank you, Madam Chair. I'm so pleased to see this committee include the Dr. Lorna Breen Healthcare Provider Protection Act as part of our work today. As the founder and now co-chair of the Bipartisan Addiction and Mental Health Task Force, this legislation was included in our recent task force legislative agenda to address the mental health needs of our healthcare providers and end the stigma in accessing treatment. As I said last week in our committee hearings on this legislation, I am constantly hearing from clinicians in my district about the current workforce crisis. An enormous contributor of that crisis is the fatigue and burnout that our frontline clinicians are experiencing daily. This bipartisan legislation will support our healthcare workforce in their own well-being, ensuring that they feel cared for as they care for others. It's critical that we remove barriers to accessing treatment and the stigma around accessing treatment for mental health and change the culture in the healthcare industry so that we can save lives and support a stronger, more vital workforce. I'm a proud co-sponsor of the Dr. Lorna Breen Healthcare Provider Protection Act, and I urge my colleagues to support this important legislation. Thank you, and I yield back.
Thank you. The gentlewoman yields back. Are there other members seeking recognition to speak on the amendment?
Ms. Craig on our side. I don't see the Republican. Ms. Craig.
Minnesota. For what purpose does the gentlewoman from Minnesota seek recognition?
Madam Chairwoman, I move to strike the last word and speak in support of the AIMS and the Dr. Lorna Breen Healthcare Provider Protection Act.
The gentlewoman is recognized for 5 minutes.
Thank you so much, Madam Chairwoman. For over a year and a half, our healthcare workers have struggled on the front lines against a deadly pandemic. We cannot overstate or over-understand the physical and emotional stress of treating countless COVID-19 patients. I've heard from providers in my district who've understandably chosen to retire rather than continue to operate under the unbearable level of stress, and obviously from so many who have suffered through mental health challenges. In 2018, the Minnesota Hospital Association surveyed over 22,000 physicians and advanced practice professionals. Their study showed 38.2% of the responding clinicians reported some level of burnout, more than double the amount reported in other fields. No doubt the COVID-19 pandemic has made a bad situation even worse. By authorizing grants for behavioral health programs, the Dr. Lorna Breen Healthcare Provider Protection Act will help prevent suicide, mental health disorders, and burnout among healthcare professionals. It would require HHS to study and develop recommendations to address provider burnout and direct the CDC to conduct a healthcare worker outreach campaign. It is heartening that we have seen broad bipartisan support for this proposal, which speaks to the magnitude of the need. I urge my colleagues on this committee to support this vital legislation. And with that, Madam Chair, I yield back.
Gentlewoman yields back. Are there other members seeking recognition to speak on the amendment? Okay. The gentlewoman from, for what purpose does the gentlewoman of Washington State seek recognition?
Madam Chair, I move to strike the last word to speak in support of the amendment in the nature of a
The
substitute to
gentlewoman is
HR.
recognized for 5 minutes.
Thank you. I wish to speak in support of the amendment in the nature of a substitute to HR 1667, the Dr. Lorna Breen Healthcare Provider Protection Act. And I am very happy the committee is taking up this important piece of legislation. After battling this pandemic for nearly 2 years, providers are exhausted. The prolonged high-intensity work combined with understaffing can take a huge toll on mental health. And as tragically with Dr. Lorna Breen, the fear of being judged or even worried that you might lose your license for seeking support can have fatal consequences. Well, this bill combats the stigma of seeking mental health care by establishing grants for employee education, peer support programming, and mental and behavioral health treatment, prioritizing COVID hotspots. It'll identify and disseminate evidence-informed best practices for reducing and preventing suicide and burnout among healthcare professionals. This bill is so important because no provider should ever worry that seeking help will put their career at risk. I got to tell you that as a physician, I know the culture of medicine. We are trained to put ourselves on the back burner, work 36-hour shifts, don't show weakness, never cry, know everything, postpone relationships, do not even think about having a family until after residency. And that's without a major health crisis. You know, all over my districts, I have heard what a toll this pandemic has taken on healthcare workers. Physicians are retiring early. Many more are considering leaving the profession altogether, despite investing years of training to become a doctor. They are overworked, understaffed, and in many cases, just demoralized from taking care of people whose illness was entirely preventable, and then who cast them as a villain when they won't prescribe what patients are asking them to prescribe. You know, it's more than doctors. There are shortages all across the provider spectrum. At one rural hospital in my district, Confluence, there are 150 open nursing positions, which is roughly a 20% vacancy rate. So doctors are unsupported. We need to pass this bill out of committee today, move it to the floor for a vote, just for the sake of all of our healthcare providers. Madam Chair, if passed, this bill will save lives. The amendment in the nature of a substitute I'm offering with Mr. Griffith today allows for technical fixes to match this language to the Senate passed version of the bill. It aligns the authorizations with the already passed provisions in the American Rescue Plan, plus adds in a Government Accountability Office study to ensure that there's no duplication of this important work. This is a bipartisan effort already passed in the Senate, and we owe it to our healthcare heroes this bill. I urge my colleagues on both sides of the aisle to support this amendment and pass the Lorna Breen Act, and I yield back.
Good work. If there's no further discussion or amendments, we'll proceed to a vote on the amendment in the nature of a substitute. All those in favor of the amendment in the nature of a substitute to HR 1667 will signify by saying aye. Aye.
Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it.
Rough night.
Coming. We're coming. The amendment in the nature of a substitute to H.R. 1667 is agreed to. The chair, the question now occurs on favorably forwarding H.R. 1667 as amended to the full committee. All those in favor of forwarding H.R. 1667 as amended to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 1667, as amended, is forwarded to the full committee. Good work, members. All right, now we're going to, the chair now calls up H.R. 3297, the Public Health Workforce Loan Repayment Act of 2021, and the clerk will please report the title of the bill.
H.R. 3297 to amend the Public Health Service Act to establish the Public Health Workforce Loan Repayment Program. In the House of Representatives, May 18th.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time. Are there any members seeking recognition to speak on H.R. 3297?
Madam Chairwoman,
For what purpose does the member seek recognition?
I move to strike the last word.
The gentleman is recognized for 5 minutes.
Thank you. While I always think it's great when this committee gets back to its bipartisan ways and holds markups with bipartisan bills, I feel it's important to point out, honestly, the irony of today's markup. On a day that we still have no idea what will be in the reconciliation spending package or when we will even vote on it, we're meeting to discuss moving bipartisan bills to help address public health initiatives, some of which may be duplicative to monies already spent in the previous relief packages or proposed to be spent in the reconciliation bill. However, we don't know because we have held no oversight hearings on the previous relief funding, and Republicans have been left out of the conversation in the reconciliation process. In the committee, we are showing again how bipartisanship works. When outside of these committee doors, unfortunately, that's the last thing that appears to be happening. We're spending reckless amounts of money with little or no oversight to see how it is spent and if it is even spent at all. For example, in the proposed spending bill being considered, apparently it sends $300 million to the FDA for IT infrastructure, yet the agency still doesn't even have a permanent commissioner in the middle of a pandemic. This committee should be demanding the administration nominated a permanent commissioner to make sure we are advancing innovative drugs and treatments and quickly responding to the pandemic, not handing them over a blank check with no oversight. It also is ironic that we're here today to say we're supporting providers, yet we are again failing to address the most pressing issue for providers currently, which are looming reimbursement cuts, and I've spoke to this before. In fact, just this week, CMS finalized the Medicare physician fee schedule rule, and the cuts are still in there. So again, I asked if today is not the right time to address them, when is? That's not even mentioning the sequester cuts and the PAYGO cuts that are pending at the end of this year. I'm all for advancing bipartisan bills. That is why I really enjoy my work on this committee so much, and I work with many people on both sides of the aisle. No committee in Congress practices more bipartisanship than the Energy and Commerce Committee. I truly believe that. That's why I think it's a shame that the same approach currently isn't being practiced outside of these committee walls. Imagine the great priorities we could advance if we all work together on such a large spending package, rather than fast-tracking trillions of dollars with completely shutting out the minority party. Again, thank you, Madam Chairwoman, for having these bipartisan bills. I'm supporting supporting them, but we really should be showing the rest of Congress how you get things done in a bipartisan way. Thank you, and I yield back.
The gentleman yields back. Are there any other members seeking recognition to speak on H.R. 3297? Democratic side? No? Yes. For what purpose does the member seek recognition?
Strike the last word, Madam Chair.
The gentleman from Florida is recognized for 5 minutes.
Thank you. Thank you, Madam Chair. I appreciate these bills moving forward, and am glad to support them. But I would be remiss if I did not speak of what's concurrently going on with the majority's reconciliation bill and the things that are being added to the package that were never even considered in the subcommittee or full committee. Why can't Congress operate like this committee operates? I can't emphasize enough how disappointed I am to see my Democratic colleagues suggest things like the disproportionate hospital share cuts to our safety net hospitals, who often provide care to the most in need in our communities. In my state of Florida, our hospital association estimates this would result in over $158 million in hospital cuts. It's really unacceptable as far as I'm concerned. These provisions put together behind closed doors seem to be directly targeted at states like mine to force them to do what Democrats want. And that's really unfair and unfortunate. It's also incredibly unfortunate to see bills that we negotiated in a bipartisan way, such as the Medicaid funding caps for Puerto Rico and the territories, be taken and thrown away just to put into a hyper-partisan package. As we know, the state of that negotiated territories bill was thrown off kilter by the Biden administration's creative interpretations of the law to make this funding permanent. Nevertheless, we acted in a bipartisan way to find a solution and a way forward. We agreed to put in a GAO legal analysis into the CR to look at CMS's interpretation of existing law that we believe does not represent congressional intent. In fact, the Congressional Research Service also conducted a legal review of the administration's decision to make territory funding permanent, which I'd like to enter into the record. And that review, CRA stated, and I quote, "To the extent that the flush text of subparagraph G2 is determined to be ambiguous, it is unclear that it is sufficiently implausible that Congress intended to return Puerto Rico Medicaid funding to levels provided as recently as fiscal year 19 to depart from the text's most natural reading." In other words, even if the law's language is ambiguous, interpreting this would most likely find that Congress intended to revert funding for Puerto Rico back to the lower levels. This means that the administration was wrong and that our bipartisan bill is still needed. I was proud to support full Medicaid funding for the territories and to get that bill enacted, along with Congressman Soto, my fellow Floridian. And yet, despite these efforts, the majority decided to turn this into a political game by stripping away our bipartisan deal and putting only their preferred partisan provisions into the package. They used a budget gimmick to take advantage of a low, inaccurate score with no accountability or oversight that was included in the bill we voted on. So while I support these bills, Madam Chair, on the docket today moving forward on a bipartisan basis, I do wonder how the majority just expects us to ignore what is simultaneously going on with the reconciliation package, and whether they're just going to turn around negotiating packages and move them through partisan reconciliation in this future. They should not be bipartisan, actually bypassing this great committee. So sadly, the precedent has already been set to do that, and it's very unfortunate. I yield back, Madam Chair. Thank you.
It was a CRS, I think it was a CRS memo.
Yeah.
Yeah, so ask them to clarify that with the.
Can you clarify the document, Mr. Bilirakis, that you sought recognition to place in the record? Was it CRS document? Okay. Dial back with me. Okay. Okay. Are there any, the gentleman yields back. Are there any other members seeking recognition to speak on HR 3297? Any on our side? No. All right. The gentleman from Florida, Mr. Dunn, is recognized for 5 minutes.
Thank you very much, Madam Chair. I move to strike the last word. Thank you, Madam Chair. I appreciate my colleagues for introducing this bill that will grow our public health workforce. I also appreciate the opportunity to evaluate each of these bills before us during a health committee workup. I'm extremely disappointed that we were not afforded the opportunity when the Build Back Better Act was marked up in this committee. That bill certainly deserved the consideration of both the subcommittee and the full committee. Today, we're making important revisions to thoughtful bills which reflect bipartisan consensus and thoughtful analysis of their impact. That didn't happen with the Speaker's tax and spending spree. Instead, in September, we were forced to debate a version of the reconciliation bill during a marathon markup with significant time constraints. Had we been given the appropriate time to evaluate that bill and learn more about its impacts and associated costs, I am sure that we would have had a spirited conversation in this committee about the merits of the pay-fors under our jurisdiction. One such pay-for that is brand new as of last week and was not included in the version we marked up months ago seeks to punish public and rural hospitals caring for the most vulnerable Americans in the wake of a global pandemic. I find this egregious and totally inappropriate. The Democrats' unprecedented attack on disproportionate share hospital, DSH, funding in red states is troubling and in bad faith. Section 30,724 of the tax and spending spree seeks to significantly slash DSH and uncompensated care pool funding, threatening the viability of Florida's rural and critical access hospitals. This section would create a dire access to care crisis in Florida and other states. The impact in Florida over just 1 year would be a loss of $32 million to our safety net hospitals. Hundreds of thousands of patients rely on care that hospitals are able to provide because of DSH funding and because of low-income pool funding. Frankly, this is a shameful, unacceptable pay-for in a bill that has been plagued by bad policy, process problems, and misaligned goals from the outset. With that, Madam Chair, I yield back.
Gentleman yields back. Are there any other members seeking recognition to speak on HR 3297?
Madam Chair, I move to strike the last word.
Who is seeking? Mr. Crenshaw. For what purpose does the gentleman seek recognition?
I move to strike the last word.
The gentleman is recognized for 5 minutes.
Thank you, Madam Chair, and I will echo the sentiment of my colleagues. Thank you for conducting this markup, and thank you to our colleagues across the aisle for working on good policy and good legislation that I plan on supporting today. But I will also echo the sentiment of my colleagues. We do have to address the elephant in the room, which is the reconciliation package that is imminent. And I want to address one particular thing, and I want to ask my Texas colleagues on the other side of the aisle, how on earth can you vote for this? How on earth can you vote for something that's so egregious and bad policy for Texas? It's not just the energy attacks. It's not just the attacks on our oil and gas workers. Because that doesn't surprise me. I've always understood that you don't value those people. But I was always under the impression that my colleagues wanted to help the most vulnerable among us and wouldn't do something that would harm them so badly. So it strikes me as strange that we would cut Medicaid dollars for a state like Texas, simply as punishment for not expanding Medicaid. So now it gets cut to the tune of $250 million in funding that goes directly to Texas safety net hospitals. These safety net hospitals that do good quality charity care for everyone. I thought this is what we wanted. And hospitals like this system, it works better, it's more direct, it's more efficient. But we're gonna cut it? We're gonna cut the disproportionate share hospital funding? And there's some backstory to this, but hey, don't worry, because at least the high earners in New York and New Jersey will get their state and local tax deductions, some of which to the tune of $36,000 in tax decreases for the wealthiest among us. So how did this happen? Well, after Biden took office, in order to punish Texas, they pulled the Texas Uncompensated Care Pool waiver on some technicality. The White House did it. They blamed it on some low-level bureaucrat, but the White House did it. Luckily, the court said this is ridiculous, and they reinstated it. So we got our waiver back, and our low-income safety net hospitals could breathe easy, and the patients that get care there could breathe easy. But for some reason, in this reconciliation package, in order to punish these kind of states like Texas, they're going to cut the DSH funding. And this is what it will do to the Houston area. This is what it will do to my district. At least $23 million in cuts to the Harris Hospital system. That's our primary safety net hospital. High quality for everyone. Again, I thought that's what we wanted. It's at least $12 million cut to the Texas Children's Hospital, one of the best in the world for treating children. $12 million cut. Another $3 million cut would be to MD Anderson, the leader in cancer treatment in the world, because they also provide charity care. But there'd be a $3 million cut to that. And then obviously that's just a couple hospitals in the Houston area. It doesn't represent the full amount of Texas, at least, which is about $250 million. This is massive. This is consequential. Without these Medicaid waivers, these hospitals will be forced to accept 50 cents on the dollar for providing care to patients. With the waiver, we can increase the payment rate to our physicians and help provide better access to care than with Medicaid expansion. So I urge my colleagues, please take a look at what is in this. Please do not support something that so directly impacts in a negative way our own constituents in Texas. It's not worth it. It's not worth the politics. It's not worth this retribution against red states because it hurts the people that we represent. Thank you, and I yield back.
The gentleman yields back. Are there any other members that wish to, for what purpose does the gentleman from Texas seek recognition?
Move to strike the requisite number of
The
words.
gentleman is recognized for 5 minutes.
And thank you, Madam Chair. So the underlying bill, or the aims to the underlying bill that we're talking about right now is important. And I do want to thank the other members, Congressman Crow, Congressman Guthrie, and Eshoo on this committee for their partnership on this important piece of legislation. And Chairwoman, thank you for your work on the amendment in the nature of a substitute to align the House version with its Senate companion. That is important if we want to see it enacted into law. I am a little bit concerned because we did originally seek and receive significant technical assistance during the writing of this bill. And I understand there is going to be an effort to seek technical assistance on the amendment in the nature of a substitute, and I would just urge that we have that in hand before we get to the full committee markup. But we all know, we all remember that before the coronavirus pandemic, our country did struggle with workforce shortages across state, local, and tribal public health agencies. So this piece of legislation would award loan repayment agreements to public health professionals who recruit a qualified workforce to end shortages across our community's public health agencies. And we've all witnessed the importance of strong public health agencies. Without robust contact tracing and testing efforts at the local level, our communities are ill-equipped to handle future outbreaks. This past year, the nation watched our public health workforce go above and beyond to defeat the coronavirus. So it is critical, as we're starting to emerge from the pandemic, that our public health workforce has the support it needs on the front lines. A strong public health workforce is critical in our fight against the coronavirus, and we know the coronavirus is, despite efforts from 2 administrations, the coronavirus is not going away anytime soon. So I'm grateful to our public health partners. I'm grateful the Public Health Workforce Loan Repayment Act was included in today's markup. But again, I would stress that technical assistance is needed on the revisions before we get to the full committee markup. Furthermore, I think we must examine the funding stream as the American Rescue Plan included over $7.5 billion for similar efforts. So we do want to be certain that we streamline the funding and not be duplicative in the efforts that we're making. So in order to prepare for the next pandemic, we need to develop creative and innovative incentives to build our public health workforce, and we should empower and support the next generation of this workforce. This bill is a step in the right direction by providing financial relief and encouraging students to pursue this path. But just like everyone else on this side of the dais, it is unconscionable that we are going through this markup and not talking about this massive reconciliation bill that is before the House of Representatives, the biggest bill that will have ever passed the House of Representatives. I remember our friend Ralph Hall telling me about days past when this committee marked up the Clean Air Act for 8 months. And now this thing is going through with scarcely a hearing in the Energy and Commerce Committee, the primary authorizing committee for easily 60% of the non-defense economy in this country. So like others, I'm concerned about the addition of Section 30,724 that cuts funding from disproportionate share hospitals from 100% of what is expected to 87.5%, and prohibit non-expansion states for implementing uncompensated care pools. I spoke about this disappointment last night during the rules debate. Now I'll say it again. Disproportionate share hospital was established to support hospitals with either high rates of Medicaid utilization or high rates of low-income populations. Section 1923B of the Social Security Act establishes that this is meant to support hospitals that go out of their way to support care for the poor. You know, our previous colleague, Gene Green, who was the ranking member of this subcommittee when I was chairman several Congresses ago, observed on several occasions how efforts to punish a state like Texas only lead to punishing the very people that we're purporting to want to help. This is misguided, it's wrong. It's wrong that it came through without a proper hearing and vetting in this committee. So apparently the Democrats have decided they only care about supporting dish hospitals in states that will conform to their wishes. And that's not the way our country was founded. That's not the way it was set up. We are a country that is governed with the consent of the governed. This looks nothing like that. I yield back.
Gentleman yields back. The chair recognizes herself. Strike the last word. I think it's important to be clear about what the Build Back Better legislation does. Because 12, as you speak of them, my colleagues, 12 red states have spent 10 years denying free health coverage to its poorest citizens. And so the legislation steps in and provides a federal option for those people so that they have health insurance coverage. There will be less uncompensated care in especially our safety net hospitals, because 4 million people will be covered, and the Build Back Better accounts for that. Now, in addition, in the American Rescue Plan, Florida could receive $3.5 billion, with a B, dollars in federal Medicare funding right now, if it, Medicaid funding, if it chose to expand Medicaid. Texas could receive $6 billion, with a B, under the American Rescue Plan. It's still on the table. $6 billion in federal Medicaid right now if it chose to expand Medicaid. So while I've always had an appreciation for safety net hospitals, I chaired the board of directors of one for a decade, and for DISH. and for Medicaid. These are extraordinarily substantial sums that would bring excellent care to people that do not have insurance today. So I think that there is clearly another side to this. I also want to accept for the record Mr. Bilirakis' request to place the CRS memo entitled Analysis of Section 1108 G2 of the Social Security Act. Are there, I think I still have some
Would you
time.
yield to me, Madam Chair?
I'd be happy to. Who am I yielding to?
Ms. Castor.
I yield to you.
Thank you very much. I really appreciate your comments, and it is important to do a little math here. You know, since the Affordable Care Act was adopted, Florida and a handful of other states have had the opportunity to draw down very significant dollars to cover a lot of our neighbors who have fallen into the Medicaid coverage gap. Florida has left about $66 billion on the table since the ACA was adopted. The fact that they have not drawn down those dollars to cover our neighbors is fiscally irresponsible, and it's morally wrong. And you are right to highlight the fact that if Florida announced today that they were moving to expand Medicaid, we would draw down about $3 to $3.5 billion. That would be about $14.3 billion over 5 years. So I know the hospitals, our community health centers, the doctors and hardworking nurses, they could really use those dollars to cover uncompensated care. So thankfully, through the Build Back Better Act, we found a way to provide coverage to, in Florida, maybe 800,000 of our neighbors there through the tax credits. It's too bad Florida and the other states still have an opportunity to do Medicaid expansion the right way, but really it's a moral imperative that our neighbors, especially in the middle of a pandemic, get the healthcare services they need and that our providers have the compensated care for their services. And remember, this Build Back Better Act is fully paid for. It will not add to the deficit one penny. So thank you, Madam Chair, for allowing me a few minutes to
Gentlewoman's time is expired. Are there other members that seek recognition to speak on HR 3297? Ms. Rogers is for what purpose does the gentlewoman seek recognition?
Move to strike the last word.
The gentlewoman is recognized for 5 minutes.
Thank you, Madam Chair. I had the opportunity to be in front of the Rules Committee last night for nearly 4 hours. The idea that the bill, the reconciliation package, is paid for is almost laughable to me. There is no CBO score. We got the text an hour and a half before we went to Rules, and there's increased spending, but yet we're still at 1.7 billion. It's like the numbers do not add up. And it's unprecedented to bring this type of a bill forward without the hearings. We are legislators. We are duly elected legislators, representatives from states all over the country. And it is important, it's fundamental that as legislators, that we do our jobs to legislate. And it just underscores the problems with this bill. And the abuse of power by a majority to impose their will upon states is so anti our form of government. We believe in states' rights. We believe in the laboratories of democracy. We don't want a federal government making all the decisions. We believe that you get better outcomes, more accountability at the state level. And within Medicaid, there are states that are doing remarkable work, that are being creative in how they structure their program in a way that is going to best meet the needs of our most vulnerable, those with disabilities, those low income, and for the federal government to impose a one-size-fits-all approach on the states, I believe is completely un-American. We should be embracing the states. We should be embracing each state, deciding what's best for them. And I know that the majority is printing a record amount of money right now, and they're throwing it at everybody. But just more money doesn't mean that you're going to get better outcomes. You need people, you need flexibility, you need the states to be doing what they think is best. And with that, I'll yield to Dr. Burgess.
And I thank the gentleman, ranking member, for yielding. If you remember the history of the 1115 waiver, which Mr. Crenshaw spoke about so eloquently, it started in 2011, and it began because the Medicaid expansion was slow to start and wasn't going to begin for another couple of years. And states like Texas and Florida, with high needs and high numbers of uninsured and underinsured patients, sought to construct their own programs. And the problem with the 1115 waiver, I would submit, is it worked too well. And then when previous administration, the Obama administration, wanted to draw it back, the states were reluctant to give it up. First they attempted with Florida, they gave Texas an extension. They thought that extension would expire during a Democratic administration, but it expired in a Republican administration, and both Florida and Texas were able to get their 1115 waivers continued. And at the end of the Trump administration, the 1115 waiver was given a 10-year authorization because it was working so well, and then the administration 4 months later pulled it back and said you can't have it. So it was really it was a bait and switch proposition. But the charge that it doesn't matter if we cut DISH and uncompensated care pools in the non-expansion states, because the states will see a net gain in federal dollars, is only partly true. And the part that's not true is really pretty painful. If you choose to just look at some of the data, you could accept that premise as being accurate, but looking at the facts, the cuts begin on at the beginning of fiscal year 2023. So that's October 1st of this year. That's not too far away. There will be a sudden burst of tax credits to low-income populations for calendar years 2023 and 2025, but then the cuts continue in perpetuity. They never go away. And all the way, while the issues of the Medicaid shortfall and uncompensated care will continue indefinitely. Low-income patients are the net losers with this policy. It's punitive and just serves one role, allowing this administration, who for some reason does not like the state of Texas, the state of Florida, the state of Tennessee, to allow it to score political wins. And again, I would just remind everyone, the whole purpose of the disproportionate share hospital, using that as an offset in the Affordable Care Act, was because when everyone was lying down in the Elysian fields of Obamacare, disproportionate share hospitals wouldn't be necessary. They are clearly necessary in states that have expanded Medicaid, because we know that, because those states are not getting cuts in their DISH compensation. If it's really true that this is something that should be proportioned equally, why would those cuts not exist in expansion states as well as non-expansion states? I'll yield back.
Gentleman's time has expired. Are there any other members that seek recognition? For what purpose does the gentleman from Georgia seek recognition?
Madam Chair, I move to strike last word.
Gentleman is recognized for 5 minutes.
Madam Chair, continuing this discussion on this massive reconciliation bill that the one that I'm talking about is the one that we didn't have enough time to debate in this committee. But then again, we're on what, the third iteration of it? So what difference does it make? It's not anything like it was before when it came before this committee. And it's so big, none of us have had a chance. And I don't know if anyone on Capitol Hill has had a chance to read the whole bill. It's so big. And therein lies the problem. There's language in this bill that would have severe consequences for disproportionate share hospitals. That's what we've been talking about. And you say it's the hospitals. It's not the hospitals. It's the patients. That's the problem in Washington, D.C. When we talk about health care, we talk about money, when we should be talking about patients. Do you realize what this is going to do? Do you think it's going to penalize the state? Do you think these 12 states that are going to suffer because of this are really going to suffer? It's the patients who are going to suffer. We've always understood, Congress has always understood the importance of Medicaid dish payments. And we've repeatedly delayed cuts to these payments. Time and time again, Congress has delayed cuts to these payments. Medicaid dish payments are intended to make up for Medicaid underpayment and uncompensated care, as hospitals generally receive about 60 cents from Medicaid compared to every dollar received from private insurance. That's what DISH was for. But Democrats are proposing a 12.5% cut to DISH allotments in the Build Back Better plan. And this cut remains in the third iteration, in the last text that was released by the Rules Committee just yesterday. I implore my colleagues across the aisle to ask themselves, why would you want to cut DISH payments to hospitals who largely serve low-income populations by 12.5% in the middle of a pandemic? Don't we realize what's going on here? Folks, I represent South Georgia, a rural area. We're suffering. We've got rural hospitals who are closing. They need help. They especially need help during this pandemic. And yet you're so set on forcing one-size-fits-all approach to Medicaid expansion on states that you'd rather put hospitals out of business, impacting the patients, and risk a patient's ability to get care. As I say, I represent a state that didn't expand Medicaid. We didn't expand Medicaid all the way to 138%, but we did receive a waiver that got us up to 100% of the federal poverty line. And there's no coverage gap in our state. There is no coverage gap in the state of Georgia at all. Yet from 0% of the federal poverty line to 100% in the state of Georgia, you get Medicaid. And from 100% up, you get Obamacare coverage. We don't have a gap. But you want to penalize us because we didn't do it the way you wanted us to do it. Because we didn't follow the cookie cutter example out of Washington, D.C. We did what we felt was best for the state of Georgia. That's what we did. Now you're choosing to penalize our state. And again, it's not the hospitals you're going to be penalizing, it's the patients. Because you're going to put the hospitals out of business, and therefore the patients are the one who are going to suffer. These proposed cuts would be as much as $7.8 billion in federal funding over 10 years. These payments keep hospitals going. They enable hospitals to care for patients in Georgia and in every other state. This Build Back Broke plan should not move forward, and these cuts should not happen. These are real cuts affecting real people. Keep that in mind. I want to yield the few remaining seconds I've got to Representative Crenshaw.
Thank you. I'll yield back.
Okay. He yields back, so I'll yield back, Madam Chair.
Gentlemen yield. Gentlemen yield.
I'll yield.
Gentlemen, can the gentleman answer to me how, if they're only affecting the states with these cuts that did not expand Medicaid, this fits in with the constitutional language in the case where the Supreme Court struck down Medicaid expansion as being mandatory on the states because they couldn't take money away from the states from an old program if they refused to implement a new program? Isn't that in violation? Isn't it exactly this plan in violation of what the Supreme Court said in their ruling when they upheld Maine Obamacare but said you couldn't expand Medicaid?
I would agree with the gentleman, and I'll yield back.
Gentleman's time has expired. The chair requests a unanimous consent request to place the following in the record: a Brookings report. The report found that DISH hospitals in the 12 states that have refused to expand Medicaid would get, under the Build Back Better legislation, $13 billion with a B dollars for uncompensated care and $2.2 billion in additional monies, essentially the profits from the volume that they would enjoy, because poor people would be covered. So I ask for.
Can we get a
Madam
copy
Chairman.
of that and then go
Yes.
through the report and then
Yeah,
we'll get it
Brookings.
before we end the
Yeah,
hearing?
It's the,
Madam Chair,
be happy to.
Madam Chair,
Yes.
if it only applies, though, to the states that did not expand Medicare, or Medicaid, excuse me, that did not expand Medicaid, have we not violated what the Supreme Court's instructions were in their case dealing with Obamacare, where they said you couldn't take money away from states because they wouldn't implement a new program? And so since we're apparently targeting those states that did not expand Medicaid, aren't we in fact going to be in violation of the Supreme Court's prior
Well,
ruling on this
I don't
matter?
believe the Supreme Court, when they undertook their review of the ACA, got into any dish cuts.
The gentlewoman would be correct in that, but they did deal specifically with dealing in any kind of a punitive manner or different manner with states that were using existing money that did not expand
Yeah,
their
well, in
Medicaid.
response to the gentleman, this is my 29th year in Congress. Most of the oil paintings in our hearing room, I've served under these chairmen. And over the years, I had fights with lots of chairmen, both Republican and Democrats, on dish cuts. I remember it very clearly with Mr. Dingell, because he was a formidable one to debate with and go up against. So the issue of dish is not, it's not canon law. It is something, it is an instrument that has been important in our safety net hospitals. I know that. I know it backward and forward because of the hospital where I chaired the board of directors, my own hospital in, not my own, but in the county that I live in when I served on the San Mateo County Board of Supervisors. So dish cuts have been debated. They've been on the table with certain percentages to be cut back under both Democratic majorities and Republican majorities. So that's, you know, I mean, that's my, giving you my firsthand experience here over, well, I've been on the committee for 27 years. This is my 29th year in Congress. Is there any other member that wishes to be recognized? The gentleman from Utah, Mr. Curtis, you're recognized for 5 minutes.
Thank you, Madam Chair and Ranking Member Guthrie. To be clear, the bills before us today have my support, but I echo my colleagues' frustrations about the reconciliation package currently being considered, which completely overshadows good faith bipartisan hearings like we're having today. Americans are dealing with runaway inflation while also seeing higher rates of drug overdose and suicides as a result of the COVID-19 pandemic. We simply cannot ignore the problems in front of us. We must work to double down on investments in behavioral health services in addition to telehealth, which reconciliation fails to address. The legislation also includes provisions that would be detrimental to the American pharmaceutical innovation and ultimately lead to higher costs to patients with limited cures for life-threatening diseases. We should be finding opportunities to work with our industry partners, patients, and providers to foster innovation, address critical health access issues, and ensure those suffering with opioid use disorder have the necessary resources to overcome the vicious cycle of addiction. The good news is we have bipartisan bills to address these problems that we've recently heard in this very committee. My legislation, for example, the HILS Act, would provide the funds to train and develop future behavioral health care workers and get more resources to communities in need across the country. I urge my colleagues to put people before politics and to work to pass policies such as the HILS Act and other bipartisan legislation that will improve long-term health outcomes. And I yield my time to my friend from Texas, Congressman Crenshaw.
I thank my colleague. I just want to address this conversation directly about Medicaid expansion. It's a good debate, and it's a debate that we should be having and will likely have for a very long time. Fundamentally, this debate is about what to do with resources. Should you engage in a one-size-fits-all policy, or should you allow some flexibility at the state level? Because I think we all want the same outcome, right? You want a a certain population to be taken care of. The question is how you do it. It was said before that if Texas would just expand Medicaid and just take those federal dollars, you'd get $6 billion.
Would the gentleman suspend? I'm sorry to interrupt you. The staff has told me that we've lost the feed here in the room, so we're going to have to.
I was on a roll.
I know, and I was paying very close attention. But I pay close attention to what everyone says, because I respect everyone. All right, let's just pause. Just take a breather, grab a cup of coffee.
Enter the event panelist numeric password, followed by pound. This meeting is being recorded.
So we were on,
All right.
it was Mr. Curtis' time.
We'll come back to order. I think that we have the green light from our engineers. Thank you for repairing whatever was broken. Where were we? I was recognizing,
Mr. Curtis.
no, Mr. Crenshaw was in the middle.
No, Mr. Curtis had.
Curtis
he had
recognized.
yielded to Mr. Crenshaw.
Oh,
So
okay.
now it's
I'll yield back to you when I'm
You'll-
done.
Yeah, Mr.
Okay.
Crenshaw.
So are there any members that, no?
It's his time.
Oh, you still have the time.
Yeah.
The chair recognizes the gentleman from Texas who we had to interrupt.
Thank you, Madam Chair. So as I was saying, this is a good debate to have over the expansion of Medicaid. And it's a debate about resources, how to help the same people, all talking about the same people, how to help them in the most efficient manner that helps them the most. And I was about to note that it was put out before that if Texas would just expand Medicaid, they might get $6 billion in federal funding. Let's assume that's true. That would be double what we're getting in federal funding from the uncompensated care program through our waiver. But the question is, does that give us a better outcome? And is it better for these hospitals that actually have to implement this care, these safety net hospitals? And the answer is no. I'd like to submit to the record this letter from these hospitals, the America's Hospitals and Health Systems, which indicate opposition to this because they like this system. It's more flexible for them. It makes more sense for them, allows them to deal directly with the state instead of the bureaucracy at CMS. They don't have to deal with patients that they only get paid and recompensated 50 cents on the dollar. This is better for these hospitals that do this great work. The point being, there's other ways to accomplish the same goal. And we should actually be happy that we're accomplishing that goal at half the price. $3 billion versus $6 billion. That should be our goal because it's not like that $6 billion is free money. It comes from taxpayers, no matter how you cut it. And we shouldn't necessarily assume that there's some inherent value in simply expanding the Medicaid population. We shouldn't assume that there's some inherent value in simply spending more dollars. It doesn't make us better people. What makes us better is if we're getting better outcomes and allowing states the flexibility to drive towards those better outcomes. Thank you, Madam Chair, and I yield back.
The gentleman yields back, and we,
No, he offered it.
he offered it, yeah, without objection. This
Yes.
letter from the America's Hospitals and Health Systems will be made part of the record. Are there any other members seeking recognition?
Madam Chair.
Yes.
Thanks, Madam Chair. Thanks for the recognition. Oh, I'm recognized, I guess. Oh, for recognition. Okay. Thank you for recognition. To strike the last word. I just want to say we do not object to the Brookings Institute article that you brought forward, so we'll accept that as well.
Thank you.
And this is a good debate to have, and I guess one of the things frustrating, I know we had a 3-day markup in September, but now we have provisions that weren't in that markup in September that we didn't get to argue out. And what my good friend from Virginia was talking about, like the things we need to talk about. What if the courts strike down the dish payment cuts, which are used as a pay-for, then we spend the money, but we don't have the pay-for moving forward. And the Supreme Court did make a ruling on dish cuts because all 50 states plus all the others were cut. Dish cuts were cut during the Affordable Care Act because the argument was that the Medicaid expansion was going to take care of the need, therefore dish cuts were not needed. Turned out that wasn't to be the case. So the issue that we say is that the 12 states that didn't expand are the ones that uncompensated care and dish cuts are moving forward. And the argument brought forth is, well, they're going to get more money, therefore it's going to offset the cuts. Well, that didn't happen with 38 other states, including mine in Kentucky. My hospitals didn't come to me and say, everybody who's showing up to our doors getting care. They were saying the dish cuts were still needed. And so those are things that we want to talk about. And I'm a co-sponsor of the bill that we're actually discussing, the Public Health Workforce Loan Repayment Act. I want to highlight that it's also part of, you had $7.6 billion funding in the American Rescue Plan almost 8 months ago. We've been told that CDC is literally creating a new program to find a way to spend almost half of the money. Between now and full committee, we asked the majority to work with us to update this legislation to ensure we aren't duplicating efforts, and we're addressing the public workforce physical cliff that's been being created. I just want to, moving forward on H.R. 3, as we know it, in the version that's moving forward, we didn't pass that out of committee. Understand there's another version. We don't really have it. We have the language and we're going through it. But we could work on bipartisan drug pricing. We have H.R. 19, 40 bipartisan drug proposals, would get Republican and Democrats to support for it. And an example in there, when I was the ranking Republican on oversight and investigations, we had hearings and helped lead hearings on the importance of lowering insulin costs, and we were able to move forward, and the Trump administration created a voluntary program for Medicare Part D, which would cap monthly insulin costs. And those are the kind of things that we could work together on. So I would just ask that our concern is there are bipartisan things we all could work together moving forward, and we're not able to do so. And then even the bill that we're going to be asked to vote on, some say early as this week, we don't have the opportunity to have the hearing on. And this is helpful to have these discussions about it. It really does affect hospitals, even though, the theory was in Affordable Care Act, you expand Medicaid, you don't have to have DSH care because everybody's covered. That just, even the states didn't expand that, turned out not to be accurate. I think people believed it, but it turned out not to be accurate as we move forward. And it won't be accurate for these other 12 states. And will be real cuts, as the letter from Mr. Crenshaw put to the record addresses. So with that, I will yield back.
The gentleman's back. Are there any other members seeking recognition to speak on H.R. 3297?
Oh, Mr. Griffith, I'm sorry.
Okay. For what purpose does the gentleman seek recognition?
Madam Chair, I would strike the last word.
The gentleman is recognized for 5 minutes.
Madam Chair, I want to associate myself with concerns of my colleagues and say that I too am very disappointed with the process by which the Build Back Better Act has moved through the House. I like the bills we're debating today, but apparently sometime in the process this week, the drug provision pricing provisions, commonly known as H.R. 3, which we did not pass out of this committee in our previous markup of Build Back Better, have gotten back into the bill. Now, as you all know, nearly 2 years ago, when this was first proposed in this committee, in the subcommittee, I raised issues of constitutionality because on its face, it is clearly unconstitutional. I stand by my arguments that by imposing an excess tax of up to 95% on certain sales, 95% of the gross on certain sales and certain pharmaceuticals, this legislative text violates the Fifth Amendment. If legislation causes property to suffer a significant diminution of value or deprivation of economically beneficial use, legislation results in a regulatory taking. I don't see how you can do 95% excise tax and say that that doesn't qualify as a regulatory taking. Now, I may want to remind you, because you might think it's just me making a partisan ploy, that the Nonpartisan Congressional Research Service agrees with my assessment. And in fact, they went one step further and said it may also violate the excessive fines section of the United States Constitution, because a punitive forfeiture violates the excessive fines clause of the Eighth Amendment if it grossly disproportional to the gravity of takes disproportionately to the gravity of a defendant's offense. Now, what's interesting about this, Madam Chair, is that I've been making this argument now for just about 2 years. This first came up about 2 years ago. No one has come up to me and said, wait a minute, Morgan, take a look at this Supreme Court case. Morgan, take a look at this legal theory to say you're wrong because it fits into this niche. Not one person has come forward. All I get are blank stares. I submit that my colleagues on the other side of the aisle and even on the floor know or ought to know this piece of legislation, this part of the bill, is unconstitutional. Further, the legislation fails to include an appropriate method of overseeing the so-called negotiation process. It states that the process of renegotiating eligible drugs would not be subject to administrative or judicial review. It also allows for the negotiation process to be implemented in years 25 and 26 without going through the rulemaking processes. This phrase, the Secretary shall implement by program, instruction, or otherwise, appears repeatedly in the drug pricing section, leading me to believe that HHS would not be required to open their process to public comment. All of this leads me to conclude that the HHS would be imposing restrictions with no public input, and there would be no judicial or administrative review of their decisions. How is that due process? I ask, how is that due process? The Fifth Amendment simply states, No person shall be held to answer for a capital or otherwise infamous crime unless held on a presentment or indictment of a grand jury, except in cases arising in the land or naval forces or in the militia when in actual service in time of war or public danger. I don't want anybody to think I'm leaving anything out. Nor shall any person be subject for the same offense to be twice put in jeopardy of life or limb. Nor shall be compelled in any criminal case to be a witness against himself, nor be deprived of life, liberty, or property without due process of law. Nor shall private property be taken for public use without just compensation. Here we're taking private property, we're taking property, and we're doing it with no judicial or administrative review of the HHS decision. We're clearly in violation of the Due Process Clause if we pass this, and so a true negotiation about drug pricing could have been worked out. We want drug pricing language too. That's why we have H.R. 19. But instead of negotiating and working together and trying to find a solution that works for American people, the Democrats, and not the Democrats on this subcommittee, and not the Democrats necessarily in this committee, but the Democrat leadership continually has decided they're going to continually beat their head against the wall and fight for H.R. 3, notwithstanding the fact that leadership knows or ought to know that drug pricing scheme is unconstitutional. I yield back.
The gentleman yields back. Are there other members that wish to speak on, let's see, it's 3297. For what purpose does the gentleman seek recognition?
Madam Chair, I move to strike the last word.
The chair recognizes Dr. Joyce of Pennsylvania for 5 minutes.
Thank you for yielding, Madam Chair. And while I do not oppose the bills that we are currently discussing, I do have serious concerns with approving new programs and new funding when we do not yet know the outcome of the latest versions of the partisan reconciliation bill, and all the while funding from the last partisan reconciliation bill remains unspent. For the last month now, the majority has been negotiating behind closed doors, trying to tie together a bill with the only requirement is that it can pass, with little regard to the long-term impacts of that chosen policy. Negotiating backwards from a top line, a price, and then trying to fill in the details, that's not a good way to legislate. And when they do release texts, it often doesn't line up with the outcomes. One such example happened just yesterday, when the text before rules appeared to state that negotiations on drug pricing may occur 10 years for biologics, in contrast, 7 years for small molecules. And the White House outline states that the drug products would be 9 years for small molecules and 12 years for biologics. Numbers matter, details matter. Notable admissions in this $1.85 trillion bill, although we have no confirmation it actually costs $1.85 trillion, is that there's no CBO score. There is not a pathway forward to avoid crippling Medicare reimbursement cuts for our frontline healthcare providers. Frontline healthcare providers who have remained steadfast during a pandemic. The cuts to the frontline healthcare providers will potentially decimate healthcare practices, particularly in the rural and underserved areas where Medicare payments make up a larger portion of their patient population. We could be working today on a bipartisan solution to this. We all know that the deadline is coming at the end of this year, and the clock is ticking. Lives are on the line. Patients and hospitals will ultimately suffer. This committee also could be working to find ways to immediately provide relief for hospitals who are suffering from constant staffing shortages, and in some dire cases, cutting back on the services that they provide to our communities. Instead, the administration is doubling down by releasing a one-size-fits-all vaccine mandate. And while we will be playing yet another game of wait and see on a partisan bill that is very unpopular with the American people and will do nothing to stop the multiple crises that we are currently facing, my plea is simple. I urge that we work together to address these issues in the bipartisan way that is a tradition of this committee. Thank you, Madam Chair, and I yield the balance of my time.
The gentleman yields back. The good doctor. Are there any other members that seek recognition to speak on the legislation?
Madam Chair.
Oh, where are you? Oh, you're up there.
Mark Wayne.
You're out there somewhere.
Sorry.
I hear your voice. Sounds like you're speaking from heaven. For what purpose does the gentleman seek recognition?
Well, if only my wife would feel the same. Madam Chair, I move to strike the last word.
The gentleman's recognized for 5 minutes.
Listen, I want to echo my colleagues' concerns too. It's hard to sit here and work in a bipartisan manner when for months we've had this socialist movement, this agenda literally ramped down our throats. And at some point we got to call it for what it is. I mean, this reconciliation bill is extreme. It moves us in the wrong direction. It takes the entrepreneurial spirit literally out of the country in a lot of aspects. It starts picking winners and losers. It starts spending taxpayer dollars in matters that we don't want them spent. And among many of the horrible provisions in this bill, it funds abortion with taxpayer dollars. I mean, 58% of Americans disagree with this policy, and many of them, including myself, have a very, very strong and deeply held beliefs against this. You know, for decades, we've had a bipartisan census on that Hyde Amendment. But yet again, the House Democrats here have caved to the far left. Really, that's what you guys have done. You guys have caved to the far left and of the party, and has taken away this very important protection. And this is absurd. And instead of continuing down this socialist path that we're running down, we should be working together like we are in a lot of the bills today, and really fixing issues that's important to the American people. And we can agree, we surely can agree on this. We see what's going on, and surely one thing, we can set some of this stuff to the side and find a bipartisan movement to say we shouldn't be funding abortions with taxpayer dollars. I mean, the Hyde Amendment has been there. And there's plenty of work that shows that. We've been working on this for decades together on this same issue. So with that, I yield back.
Would the gentleman yield to me his remaining time?
Yes, ma'am, I'd love to.
I appreciate it very much. The following is according to the Kaiser Family Foundation, and we can provide the item for the record with the minority. Mr. Crenshaw asked about the inherent value of Medicaid coverage for patients. Now, this is according to the Kaiser Family Foundation. Here are the facts. It's been shown that Medicaid enrollees, A, have better access to care than the uninsured. B, they are less likely to postpone care. Medicaid coverage leads to a decline in infant and child and teen mortality. C, it also lowers rates of hospitalizations and ER visits later in life. And D, it reduces mortality among adults. This is worthy for the record. If the and we'll get the paperwork to the minority.
Madam
yes,
Chair, I don't, reclaiming my time.
Sure.
I don't see where that has to do with the Hyde Amendment. What we're talking about with the Hyde Amendment is literally.
I just wanted to use the time to make the statement relative to Mr. Crenshaw's. I didn't have any time from my side.
I was confused there because I have a hard time understanding what that had to do with the Hyde Amendment when that's not what I was bringing up. So I get that. I yield back.
I should have said so, then you wouldn't have yielded your time to me, but I appreciate it. Gentleman yields back. Are there any other members that wish to speak on the bill? That's it? All right. The chair recognizes herself to offer an amendment in the nature of a substitute. The clerk will report the amendment, please.
Amendment in the nature of a substitute to H.R. 3297, offered by Ms. Eshoo of California. Strike all after the enacting clause and insert the following.
Without objection, the reading of the amendment will be dispensed with, and I recognize myself for 5 minutes. Our nation's public health infrastructure is in peril. Public health departments have been underfunded and understaffed for years, and the public health workforce is facing extreme shortages with no framework for the revival, retention, or repayment of workers. This neglect, I think all the members of this subcommittee know, was on full display last year when public health departments were unable to respond effectively to the COVID-19 crisis. Public health agencies are currently warning us that temporary emergency funding won't do enough to address the workforce shortage. For example, yesterday, Kaiser Health News published an article titled, "Labs with No One to Run Them: Why Public Health Workers Are Fleeing the Field." In it, Donna Ferguson, a director of a public health lab, stated, "The biggest threat right now is not the next emerging pathogen, but labs closing due to lack of staffing." It's time to rebuild the pipeline for health department workers and ensure a lasting and successful workforce to better prepare our country to address future public health crises. The Public Health Workforce Loan Repayment Program is a bipartisan bill that would promote the recruitment of public health professionals at local, state, and tribal public health agencies to ensure that they're well-coordinated preparedness efforts and responses to pandemics and infectious disease threats. The legislation is supported by the National Association of County and City Health Officials on behalf of the country's nearly 3,000 local health departments. I offer the aims to make several technical changes to the eligibility requirements of the student loan repayment program and to move the authorization period forward to fiscal 23 and 27 to align with the appropriations cycle. And I'm proud to co-lead this legislation to offer this aims, and I urge my colleagues to support the bill and its amendment. Okay. Let's see, where are we? Are there any other members seeking recognition to speak on the amendment?
Let me go first. Madam Chair, I can request, seek to strike the last word.
The gentleman is recognized for 5 minutes.
Thank you. I'm just going to be really brief. I just wanted to point out that I know the Kaiser Foundation report, I think we're reviewing that, and we'll get back with you on that. Okay. But it compared Medicaid versus the uninsured. It said that Medicaid has better results than the uninsured. And Mr. Crenshaw isn't here right now, but I don't think that's what he was advocating for whatsoever compared to uninsured. It was that states can do other things with money to be flexible and be innovative and entrepreneur, that they could do other things with the same dollars to make sure people are covered. And so he wasn't comparing Medicaid versus uninsured. It was Medicaid versus other alternatives that Texas has in place. So I just wanted to clear that up for the record. And I yield back.
It was my understanding that he asked about the inherent value of Medicaid coverage for patients, and that's why I placed that in the record. But, you know, I mean, we have differing views. What we put in the record, each side believes has value, and it's important to have that. I don't see, oh, I'm sorry. For what purpose does the gentlewoman from Washington seek recognition?
Madam Chair, I'd like to strike the last word.
Gentlewoman is recognized for 5 minutes.
Thank you, Madam Chair. I'm pleased to support the Public Health Workforce Loan Repayment Act, which establishes a loan repayment program to promote the recruitment of public health professionals. We have a long list of important bills before us today. However, one of the most heart-wrenching questions before Congress right now is whether the majority will impose their radical position on mandating taxpayer funding of abortion on our country. Abortion is one of the most divisive issues in America. It pierces every heart. And the question before this committee today, as many times before, is whether taxpayer funding should be used to fund abortions. We know that the vast majority of Americans believe taxpayer dollars should not be used to fund abortions or subsidize insurance plans that cover abortions. The Hyde Amendment has been the law of the land for decades, with support from Republicans and Democrats. However, Democrats on this committee are now demanding the elimination of Hyde. It's just the latest example of the extreme agenda being driven through this Congress. I want to be clear that abandoning Hyde is not the will of the people. Until recently, abandoning Hyde protections wasn't the position of President Biden. But it seems his political agenda is now driven by extreme activists. Democrats passed the American Rescue Plan and the fiscal year 2022 discretionary appropriations bills without the critical Hyde protections. And they're doing the same now with this massive reconciliation package to achieve what they say is transformational change in America. The bills before us today authorize discretionary appropriations that in the past would be subject to the Hyde Amendment, in addition to directing taxpayers to pay for abortions through the passage of the deceptively named Women's Health Protection Act. Democrats want these federally funded abortions to be available at any time, on demand, up until birth. It's an extreme agenda that's being rammed through Congress through the unprecedented pro-abortion policies in the reconciliation package. Under that bill, if low-income women want to buy a health plan and use tax credits, they must purchase a plan that covers elective abortions. If a woman is pro-life and does not want health insurance that pays for abortion, she's on her own. In addition, because Democrats have rejected Hyde, the $20 billion in duplicative, unnecessary public health spending in the bill could be used for abortion training, services, and facilities. This is radical. The Hyde Amendment has been supported and renewed annually on a bipartisan basis multiple times for decades. Less than a year ago, Democrats all supported Hyde protections fundings for community health centers, teaching health centers, and the National Health Service Corps. It's wrong. And it's not the will of the American people. The vast majority, 58%, believe taxpayer funding of abortion should not be used to fund, or taxpayer dollars should not be used to fund abortions or subsidize insurance plans that cover abortions. Now, I know my friends on the other side will counter this argument with competing surveys over Roe v. Wade. But I want to make clear that I'm not talking about people's opinions regarding the legality of abortion or access to abortion services. The issue before us right now is whether to federally subsidize abortions with taxpayer dollars. The reality is that most Americans do not want to be forced to use their taxpayer dollars to fund something that goes deeply against their conscience. It's just one of the many reasons why this massive reconciliation bill is bad policy and should be rejected. I yield back, Madam Chair.
Gentlewoman yields back. Are there any other members that wish to be recognized to speak on the underlying bill? Hearing, seeing none. Where are we? Oh, okay, because I already offered it, right? All right, if there's no further discussion or amendments, we'll proceed to a vote on the amendment in the nature of a substitute. All those in favor of the amendment in the nature of a substitute to H.R. 3297 will signify by saying aye. 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 All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. Whoops, excuse me. All right, the question now occurs on favorably forwarding H.R. 3297 is amended to the full committee. All those in favor of forwarding H.R. 3297 as amended to the full committee will signify by saying aye.
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 All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. I record that, well, we already did. The next one, all right. HR 3297, as amended, is forwarded to the full committee. All right, now where are we? 3320. The chair now calls up HR 3320, the Allied Health Workforce Diversity Act of 2021, and the clerk, please, will report the bill.
HR 3320 to amend Title VII of the Public Health Service Act to authorize assistance for increasing workforce diversity in the professions of physical therapy, occupational therapy.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time. Are there any members seeking recognition to speak on HR 3320? All right.
Madam Chair?
Yes, for what purpose does the gentlewoman seek recognition?
Madam Chair, I have an amendment at the desk.
The gentlewoman is recognized for 5 minutes. The clerk has to report the amendment. I'm sorry, Ms. Matsui. Would the clerk please report the amendment?
Amendment to HR 3320 offered by Ms. Matsui of California, page 2, lines 8 and 9, strike.
Without objection, the reading of the amendment will be dispensed with, and the gentlewoman from California is recognized for 5 minutes.
Thank you, Madam Chair. The Allied Health Workforce Diversity Act invests $40 million in funding to increase diversity in America's healthcare workforce and helps us attract, recruit, and retain students from underrepresented backgrounds. This is especially important in the fields of occupational therapy, physical therapy, and speech-language pathology, where over 77% of health professionals are white. For patients of color, we know that patients have better outcomes when seen by healthcare providers who speak the same language or share a similar cultural background as themselves. My amendment incorporates a technical fix to remove the limited list of accreditation bodies and expands the pool of eligible accredited programs that can benefit from this bill. I want to thank Representative Bobby Rush and Mark Wayne Mullen for their leadership in championing this legislation. I ask my colleagues to support adoption of this amendment and the underlying bill. Thank you, and I yield back.
The gentlewoman yields back. Are there any other members that seek recognition to speak on the amendment? Not hearing or seeing any. Let's see where we are. Next page. If there's no further debate, we'll proceed to a vote on the amendment. All those in favor of the amendment will signify by saying aye.
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 Aye. Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. The amendment is agreed to. Are there any further amendments to this legislation? No. The question now occurs on favorably forwarding HR 3320 to the full committee as amended. All those in favor of forwarding HR 3320 as amended to the full committee will signify by saying aye. Aye.
Aye. Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. Okay. HR 3320, as amended, is now forwarded to the full committee. Okay, moving right along here. The chair calls up HR 3537, the Accelerating Access to Critical Therapies for ALS Act. And the clerk will please report the title of the bill.
HR 3537, to direct the Secretary of Health and Human Services to support research on and expand.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read.
Madam Chair?
The chair recognizes herself for 5 minutes to strike the last word and speak on the bill and its aims. The act, pardon me, oh, I'm sorry.
Ms. Rogers needs to offer the aims.
Oh, okay. Well, I will speak on the bill then, okay? Thank you. The Act for ALS is the most popular bill in the United States House of Representatives with 326 bipartisan co-sponsors. This is because of the hard work and the tenacity of the bill's sponsors, Representatives Quigley and Fortenberry, as well as the ALS advocates who will not allow Congress to ignore their suffering. ALS affects 1 in 300 people. Within 3 years of diagnosis, most patients die because they're robbed of the ability to move, speak, and breathe. In the United States, every 90 minutes, someone dies from ALS. We can't treat this disease as business as usual. We have to increase funding for science, for clinical trials, for expanded access, and accelerated regulatory approval for ALS treatments to move the needle on this dreaded disease that is truly a death sentence. The Act for ALS meets this urgent need by helping more patients receive experimental treatments through expanded access programs. The Expanded Access Program is especially critical for ALS patients because more than 50% of people with ALS do not qualify for clinical trials and are often given no treatment options whatsoever. Importantly, as we heard at our hearing from Harvard's Dr. Merit Sudkovic, expanded access programs do not prevent or interfere with controlled, well-designed clinical trials. Instead, expanded access is for people who are ineligible for existing clinical trials. So this legislation, along with the changes made in the AIMS, allows for more people to have expanded access to experimental treatment in parallel with well-designed clinical trials. Dr. Sudkovic also testified about how expanded access can help researchers learn about ALS. In the expanded access program she runs at Harvard, she was able to research how to best dose the medication as well as record improved patient functions from the treatment. This legislation and its aims provides a framework to allow NIH and FDA to benefit from this type of research from the expanded access programs. Colleagues, this is a transformational bill to make sure people with ALS are given treatment options and something they all deserve. They all deserve. They all deserve to be able to hope. So I urge all of my colleagues to support the bill. I salute the sponsors, the bipartisan sponsors. Again, Mr. Quigley, Mr. Fortenberry, all those that have co-sponsored the legislation. And thank again the witnesses that traveled across the country under really difficult, trying circumstances to be here in this hearing room to give their moving testimony. Oh, he's here. Oh, I'm sorry. I'd like to acknowledge that our colleague, Mr. Quigley, is here in the hearing room. Thank you for your superb work. And this is a big step, and we may not be able to hear the applause across the country, but it's there. We made a promise during the hearings on both sides of the aisle, and I don't know how many of you read the comments that were online. they were so heartfelt. I mean, I cried reading them. So with that, colleagues, I know everyone is going to vote for this, and bravo to the committee members. And again, Mr. Quigley, thank you for being here today to witness this, and to Mr. Fortenberry. They really have been so undeterred. They have worked and worked and worked and worked. This is a huge accomplishment on behalf of a community in our country that has really captured the sincere attention and action of the Congress. Now, let's see, who would like to be recognized? For what purpose does the gentleman from Washington seek recognition?
Madam Chair, I have an amendment at the desk.
Okay. The gentlewoman is recognized for 5 minutes. No? Oh, we have to get the title of it, yeah. The clerk needs, would the clerk please report the amendment?
Amendment in the nature of a substitute to H.R. 3537, offered by Mrs. Rogers of Washington. Strike all after the enactment.
Without objection, the reading of the amendment will be dispensed with, and Ms. McMorris Rogers is recognized for 5 minutes.
Thank you, Madam Chair. First, I want to join in saluting all the members, the advocates, the individuals that are battling this dreaded disease in their advocacy on this legislation. This is a bipartisan amendment that I'm offering with Chairman Pallone that incorporates feedback that we received from HHS and will require the Government Accountability Office, GAO, to conduct a study on the implementation of the grant programs created under the bill. I want to thank Chairman Pallone as well as the sponsors, Mr. Quigley, who's in the room, Mr. Fortenberry. Truly, they've led an extraordinary effort in the entire ALS community for working together to get this bill where it is today. As we've heard from our witnesses back in July, ALS and other neurodegenerative diseases are life-altering. They impact both patients and their families' lives in unimaginable ways. Yet despite the challenges they face, the patients and caregivers we heard from were filled with hope. Hope that future generations may not have to suffer the same obstacles they face in accessing promising treatments. Hope that one day there will be a cure. Hope for life-saving treatments and cures is here in America. We cannot forget that. We've led the world in discovering and developing breakthrough medicines. America is where hope becomes a reality. This legislation builds on our success as the leader in medical ingenuity. It will help us further understand the neurodegenerative diseases so that we can advance in our efforts to find new cures and treatments. It will facilitate access to promising investigational therapies for those who otherwise would have had no options. It provides another reason to feel hopeful about our future. I urge a yes vote on this amendment and on the passage of the underlying bill. I yield back.
Gentlewoman yields back. Are there other members seeking recognition to speak on the amendment?
Madam Chair,
Yes.
Mr. Curtis.
I move to strike the last word.
He's on the internet.
Another voice from heaven. Mr. Curtis of Utah is recognized for 5 minutes.
Thank you, Madam Chair and Ranking Member. I speak with a little bit of hesitancy because of the personal nature of this. I lost a good neighbor about 4 years ago to ALS. Surprisingly, a gentleman moved in across the street from me a little over a year ago, and he passed away. And a very good friend about 2.5 blocks away passed away last year. And last Saturday, I visited a good friend for the very last time, Osborne, who passed away Monday from ALS. Warren and I and our families had vacationed together. We had worked together. We had served in the community together. And Warren was unique because he had near unlimited resources. He was what I would call a super entrepreneur. He had the ability to fly around the world for treatments and tried treatments that he couldn't take care in the United States. Unfortunately, much of this time, he was away from his family in the few years that he had left because these treatments were not available in the United States. And of course, to many who suffer from ALS, they have no ability to access these treatments. I feel in many ways that we've let these good people down, that these treatments that show some promise are unavailable to them, and they find themselves, as we heard in the hearing, so desperate for anything that would give them hope. So I speak in great support of this bill, and not just this bill, but a continuing commitment of me and I expect all of us to find more answers for our good friends, to make sure that we stop losing them to this very terrible disease. And with that, Madam Chair, I yield back.
Would the gentleman yield? It's Kathy.
Yes. Hi, Kathy. Yes, I yield to.
Thank you.
Yes.
I too just wanted to recognize and thank the leadership of Chairman Anna Eshoo in making sure that this legislation is passed and that we are giving options to our ALS patients. I meant to do that earlier, so just appreciate your commitment and leadership in getting the job done. I yield back, or I yield, back to the
Yes.
Gentleman yields back. Thank you to both members for your beautiful comments. Are there any other members that seek recognition to speak on the amendment? Not hearing or seeing any that seek recognition. There's no further debate. We'll proceed to a vote on the amendment. All those in, it's the Ains, yeah. A vote on the amendment in the nature of a substitute. All those in favor of the amendment in the nature of a substitute to HR 3537 will signify by saying aye. Aye?
Aye.
Aye.
Lots of ayes. That's music to everyone's ears. Is there anyone that dares to vote no? Not hearing any. In the opinion of the chair, the ayes have it. The amendment in the nature of a substitute to HR 3537 is agreed to. The question now occurs on favorably forwarding HR 3537 is amended to the full committee. All those in favor of forwarding 3537 is amended to the full committee will signify by saying aye. Aye.
Aye.
Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. Hallelujah. All right. Do I have to read this? Who invented all of this? Yes, all right. Do I need to say this? HR 3537, as amended, is forwarded to the full committee. Wonderful work, members. That's a big one. Okay, now, the chair calls up 4555, the Oral Health Literacy and Awareness Act of 2021. The clerk will please report the bill.
HR 4555 to amend the Public Health Service Act to authorize a public education campaign across all relevant programs of the Health Resources and Services Administration to increase.
Without objection, the first reading of the bill will be dispensed with, and
Chairwoman.
the bill is now considered as read. Without objection, the bill is considered as read and open for any amendment, at any point. Are there any members seeking recognition to speak on HR 4555?
Seek to be recognized to strike the last word. This is Congressman Cardenas.
The gentleman from California is recognized for 5 minutes.
Thank you, Madam Chairwoman, and I'd like to thank all of my colleagues for all of your wonderful support for this legislation, HR 4555. When it comes to oral health literacy and awareness, This act will do much to make sure that we improve the lives and the health and the well-being of all people in our great country. I'm so glad that we're marking up all these 9 bills today, including this bill. I want to give a special thanks and a shout out to my good friend and colleague, Congressman Bill Arakis, for co-sponsoring this bill. Millions of Americans have often neglected their oral health without understanding the long-term effects on their overall health. Tooth decay is the most common chronic illness among school-age youth. That's our children, ladies and gentlemen, affecting roughly 1 in 4 children. I said chronic. In 2012, almost 1 in 5 Americans 65 and older had untreated cavities or other, and also 40% had gum disease. In terms of people across our great country in 2016, less than half of all American adults and adolescents and teenagers visited a dentist in 2016. That means just right here in Los Angeles, that's over 3 million people, men, women, and children, who have gone without dental care. These numbers are especially bad in communities where there are barriers to access and coverage for dental care and other healthcare needs. Education, in addition to access and coverage, are all important pieces for making change. In fact, most oral health ailments can be avoided by regular preventative healthy habits. For all these reasons, I'm grateful for the inclusion of my bill in today's markup, and I urge a yes vote from all of my colleagues. And once again, many of the things that we can do in our great country are preventative, and this bill, when it comes to education and literacy and awareness about people's oral health, this act will do much to improve the lives of all Americans and our economy. With that, Madam Chairwoman, unless somebody wants part of my time, I will yield back.
Gentleman yields back. Are there any other members that would like to speak on HR 4555? Hearing and seeing none. We don't have any amendments. And so, no amendment, no amendment. There's no further debate. We'll proceed to a vote. The question now occurs on favorably forwarding HR 4555 to the full committee. All those in favor of forwarding 4555 to the full committee will signify by saying aye. Aye. Aye.
Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. Let's see. HR 4555 is forwarded to the full committee. The chair now calls up HR 5487, the Stillbirth Health Improvement and Education for Autumn Act of 2021, or the Shine for Autumn Act of 2021. And the clerk will please report the bill.
HR 5487 to improve research and data collection on stillbirths and for other purposes.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point.
Madam Chair?
Madam Chair.
It's Mullen.
Mr. Mullen has the Ames.
Okay. The gentleman from, what state? I forgot. Oklahoma is recognized.
Madam Chair, I have an amendment to this.
We need, what is your amendment labeled?
Oh, is it just an amendment?
Is it an amendment?
Then let's go to Ms. Castor first, because she wants to speak on the bill.
Oh, all right. Mr. Mullen, because you have an amendment, we're going to take, I'm going to recognize Ms. Castor to speak on the underlying bill first.
Okay.
Excuse me. The chair recognizes the gentlewoman from Florida for her 5 minutes.
Thank you, Madam Chair. I move to strike the last word to speak in favor of the Shine for Autumn Act. Thank you very much for holding this important markup today and for including the Shine for Autumn Act. A month ago, I introduced the Stillbirth Health Improvement and Education for Autumn, or Shine for Autumn Act, with Representatives Herrera Butler, Roy Ball Allard, and Rep Mullins. This bill is named after Autumn Joy, who was stillborn on July 8th, 2011. Her mother, Debbie, has turned Autumn's tragic death into a mission to increase stillbirth awareness and education and to lower stillbirth death rates, which is the aim of our Shine for Autumn Act today. And I'm proud to help lead this legislation and keep the memory of Autumn Joy alive. As we heard during our recent hearing on the bill, stillbirth rates are unacceptably high, with approximately 24,000 babies being stillborn in the United States each year. We rank 25th among 49 high-income countries with respect to stillbirth rates. Stillbirth is 2.1 times more common among Black mothers than white mothers, which is attributed to the impacts of racism on health. This heartbreaking loss can happen in any family, though, and yet there's still so much that we do not know about stillbirth. That's why the Shine for Autumn Act seeks to improve surveillance and data collection relating to stillbirth and invest in research to examine the causes of stillbirth and its risk factors. Additionally, it would seek to increase education and awareness. American parents deserve better data and science to help improve pregnancy outcomes and health in our community. So I'm pleased that we're taking up this bill, and I ask our colleagues to support the Shine for Autumn Act today. Thank you, and I yield back.
The gentlewoman yields back. Are there other members that would like to speak to the underlying bill, 5487? Not seeing or hearing any. Are there any members seeking recognition to offer a bipartisan amendment?
Madam
Mr.
Chair.
Mullen? Mr. Mullen, you're recognized.
Madam Chair, thank you again for holding this very important markup.
Oh, I'm
including
sorry.
My bill.
I'm sorry.
Yep.
The clerk needs to report the amendment.
Amendment to H.R. 5487, offered by Mr. Mullen of Oklahoma, page 2, line 13, strike and.
Without objection, the reading of the amendment will be dispensed with, and the gentleman is recognized for 5 minutes. Thanks for your patience.
Absolutely. Well, thank you again for holding this very important markup and including my bill, the Shine Act or the Shine for Autumn Act. The United States ranks 25th for the number of stillbirths among high-income countries. In 2019, over 21,500 babies were stillborn in our country. This is honestly unacceptable. The Shine for Autumn Act claims to lower the U.S. stillbirth rate by providing resources to state and federal health departments, improving data collection, for instance, of stillbirths, and increasing education and awareness of stillbirths. My simple amendment makes clarifying technical changes to include stakeholder feedback and improve the research and data collection outlined in this bill. Again, thank you for moving this bill quickly through the committee, and I urge a yes on this vote, and I yield back.
The gentleman yields back. Are there any other members, that seek recognition to speak on the amendment? Not seeing or hearing any. If there's no further debate, we will proceed to a vote on the amendment. All those in favor will signify by saying aye. Aye.
Aye.
All those opposed? No. The ayes have it. The amendment is agreed to, and there aren't any further amendments. Now a recorded vote. No? Not yet. Yeah. The question now occurs on favorably forwarding H.R. 5487 to the full committee as amended. All those in favor of forwarding H.R. 5487 as amended to the full committee will signify by saying aye. Aye.
Aye.
All those opposed will signify by saying no. In the opinion of the chair, The ayes have it. Okay. Come on. HR 5487, as amended, is forwarded to the full committee. Thank you, colleagues. That's a very good bill. I've always found the issue of stillbirths to be something that is haunting, just haunting, and the trauma of it remains with families, I think really over a lifetime. The chair now calls up HR 5551, the Improving the Health of Children Act, and ask the clerk to report the bill, please.
HR 5551 to amend Title III of the Public Health Service Act to reauthorize the National Center on Birth Defects and Developmental Disabilities and for other purposes. In the House of Representatives.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time. Are there any members seeking recognition to speak on HR 5551? For what purpose does the gentleman from Georgia seek recognition?
Madam Chair, I've got Ains at the desk.
The clerk will report the amendment, please.
Amendment in the nature of a substitute to HR 5551 offered by Mr. Carter of Georgia. Strike all after the enactment.
Without objection, the reading of the amendment will be dispensed with, and the gentleman from Georgia is recognized for 5 minutes.
Thank you, Madam Chair, and thank you for bringing up this bipartisan legislation today. This is a very important bill. As we all know, the National Center on Birth Defects and Developmental Disabilities does phenomenal work to detect, prevent, and research birth defects and intellectual disabilities for a wide range of conditions. They also provide much-needed educational resources to parents and caregivers about the conditions a child may have, and they work to raise awareness about conditions that may be hard to identify. Unfortunately, the center has been operating under an expired authorization since 2007. We must not forego our commitment to these children. This legislation reaffirms congressional support of the center, expands the scope to study more conditions, and provides an increased authorization so that they can continue to carry out the great work they do. I want to thank the bipartisan supporters of this legislation for the help in authorizing this bill, Representatives Stryan, Butterfield, and Hudson. And I urge a yes vote today so that we can get this legislation to the full House. Thank you, Madam Chair, and I yield back.
The gentleman yields back. Are there other members seeking recognition to speak on the amendment?
Madam Chair.
Oh, I see. Oh, good to see you.
Good to see you.
For what purpose does the gentlewoman seek recognition?
Madam Chair, I would like to strike the last word and speak in support of my amendment in the underlying bill, HR 5551, the Improving the Health of Children Act.
The gentlewoman is recognized for 5 minutes.
Thank you, Madam Chair. The Improving the Health of Children Act will reauthorize the National Center for Birth Defects and Developmental Disabilities at the CDC for the first time in 15 years. The bill expands the center's role and authorizes new funding that will enable the agency to continue to carry out programs and research that have been instrumental in advancing the health and well-being of the nation's most vulnerable populations. The center promotes the health and well-being of mothers and babies through surveillance, research, and prevention of birth defects and infant disorders, enhances understanding of developmental disabilities so children can live their fullest lives, and improves the health of people living with disabilities. My amendment with Mr. Carter increases the authorization amount as well as expands the scope of programmatic activities to better reflect the critical work at the center. As this committee continues to advance new and critically needed policies, it is equally important to invest in the established programs in place that improve the health of mothers, infants, and families. This bill does just that, and I urge my colleagues to support it today. Thank you, Madam Chair. I yield back.
Gentlewoman yields back. Are there any other members that wish to be recognized to speak on the, are we on amendment? On the Ains? Not seeing or hearing any members. We will go to the vote. Bear with me. Thank you. There's no further discussion or amendments. We will proceed to a vote on the amendment in the nature of a substitute. All those in favor of the amendment in the nature of a substitute to H.R. 5551 as amended will signify by saying aye. Aye.
Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. The amendment in the nature of the substitute to H.R. 5551 as amended is agreed to. It wasn't amended. I'm sorry. Should I restate it? The amendment in the nature of a substitute to H.R. 5551 is agreed to. The question now occurs on favorably forwarding H.R. 5551 as amended to the full committee. All those in favor of forwarding H.R. 5551 as amended to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. Okay. Those in, here, right? H.R. 5551, as amended, is forwarded to the full committee. Amen. And we're close to the big amen. We have one more, okay? Good work, everybody. The chair now calls up H.R. 5561, the Early Hearing Detection and Intervention Reauthorization Act, and the clerk will please report the bill.
H.R. 5561 to reauthorize a program for early detection, diagnosis, and treatment regarding deaf and hard of hearing newborns, infants, and young children, and for other purposes. In the House of Representatives, October 12th, 2021.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. Are there any members seeking recognition to speak on H.R. 5561? For what purpose does the gentleman seek recognition?
Chair, I'd like to strike the last word.
The gentleman is recognized for 5 minutes.
Thank you. I just want to thank Representative Matsui for her leadership. Over the years, working with me on the Early Hearing Detection Intervention Reauthorization Act, we have worked together on this important bill since 2015, and I'm glad we are continuing to address this issue. This legislation would authorize successful EDDI program for early hearing detection, diagnosis, intervention for newborns and infants and young children, while also increasing the focus on loss to follow-up services. So those children with hearing loss is identified, don't just stop with identification. Through early detection, families can be made aware of an infant or child's hearing loss and receive guidance on the best practices moving forward. These families are provided all information to make important decisions with respect to a full range of assistive hearing technologies and communication modalities they find most appropriate for their child. Urge my colleagues to support the Early Hearing Detection and Intervention Act so we can continue these vital services. I thank my friend Ms. Matsui for working with me on this like we did on so many other things, and I yield back.
The gentleman yields back. Are there any other members that wish to seek recognition?
Madam Chair,
The gentlewoman from California is recognized for 5 minutes.
Madam Chair, I move to strike the last word.
You're recognized for 5 minutes, my friend.
I also want to voice my support for this important legislation that will reauthorize funding for the Early Hearing Detection and Intervention Program. This program has helped states significantly increase the number of infants screened for hearing loss, and frequent screening has led to a marked reduction in loss to follow-up treatment, meaning more kids identified with hearing loss are being connected with the diagnostic and early intervention care they need. Additional funding for this program will help strengthen the hearing loss identification and reduce diagnostic and intervention service gaps. Unaddressed hearing loss in infants can have a significant impact on communication skills, language development, and learning. And I remain concerned about hearing care disparities in medically underserved communities. As we move forward with this important legislation, I encourage the committee to consider how we can work to address disparities by improving CDC's data collection and surveillance of the state EDI programs. A status check from our federal partners on the quality and effectiveness of these screening programs is critical to identifying specific areas in need of additional support. We have a real opportunity here to lay a foundation that will enhance connection to follow-up services among racial and ethnic minorities in the future. I really did enjoy working with my colleague, Representative Guthrie, as we do on many matters, and I do look forward to working with the committee on these improvements before we reach full markup. Thank you, and I yield back.
The gentlewoman yields back. If there are no further seeking from recognition, no further debate, we'll proceed to the chair now what? Oh, good, we're just got no amendments. Look at this, we can go straight to the bill. The question now occurs on favorably forwarding 5561 to the full committee. All those in favor of forwarding HR 5561 to the full committee will signify by saying aye. Aye.
Aye.
All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. Let's see. HR 5561 is forwarded to the full committee. All right, without objection, the staff is authorized to make technical and conforming changes to the bills consistent with the actions taken by the subcommittee today. And I now request unanimous consent to enter into the record the following documents.
Can I review those? And you want to read them out or just?
I'll read them out.
Okay.
A letter from ALSA in support of HR 3537, a statement from Representative Fortenberry of Nebraska in support of his legislation 3537, a statement from Representative Quigley of Illinois in support of his legislation 3537, statement from the ALS Association in support of 3537. Thank you, ALS Association, for everything you've done from all of us. A letter from the Delta Dental Institute, a document from JAMA Surgery entitled New USPSTF Guidelines for Lung Cancer Screening, Better but Not Enough. A statement from the Muscular Dystrophy Association in support of HR 3537. A statement from Debbie Hain, Vijay Verghia, Mother of Autumn, in support of HR 5487. Thank you, Mother of Autumn. Remarks from Representative Hudson of North Carolina on HR 5551, and an article from the Kaiser Family Foundation entitled, quote, 10 Things to Know About Medicaid, Setting the Facts Straight, unquote. Are there any objections to placing?
I don't think we have it. Do we have it with us with Andy Bard? No, he's going to submit. Andy Bard's going to submit a statement for the record for the Carroll Act. Is that?
No, I'd be happy to include that in this unanimous consent request.
Okay.
So ordered. Thank you, Mr. Guthrie. I think that's it, right? Okay, it's been wonderful to be together. Thank you to the staffs on both sides of the aisle for the work that they did. Thank you to our engineers that got us hooked back up again. And to all the members of the subcommittee, thank you for your important work. The Health Subcommittee now stands adjourned.
Thank you.
Thank you, ma'am.